It's 8 o'clock. We've got a pretty full agenda today, so we want to make sure that we have plenty of time to get through it. Welcome to third quarter town hall. Uh, Christine, if you can advance the slide for me. Thank you. So I'm going to go over real quick our agenda for today, but just really want to kick off our meeting today. It's our going to be our 1 year anniversary for our Epic Go Live, believe it or not. Think of where we were a year ago with all the training and getting ready and running around. And here we are 12 months later, really maximizing Epic. So it's been a learning journey. I would venture to say that in the next 12 months, we're going to continue to refine how we're using the system to maximize it. And I know Dave and our advisory group are going to spend a little bit of time today going over some of those changes that are going to maximize how we utilize Epic. So happy anniversary to all. Everyone's efforts really paid off for this transition. And then we'll go through a patient story, value-based purchasing. Ariel has some metrics and some updates. And then, as I said, our Epic Advisory Group will speak on several different topics. And then Dottie will give us some rehab updates. And then I'll give some projections for our October meeting. All right, so let's get things kicked off then. We wanted to bring forward a patient story, and one's brought in reference to Sue Bellamy, who's our physical therapist on our East Market. And it reads, I received a phone call recently from East 3 patient KR who wanted to compliment Sue Bellamy, PT, for tremendous support she's provided. KR shared that Sue's efforts, she can now sit up in a chair for longer periods and even converse while sitting up on the side of her bed. KR has been living with progressive MS for 26 years and has been paraplegic for 4. She's been struggling with debilitating vertigo, but Sue has equipped her with helpful tools to manage and distract her from it. KR is now using a sliding board for transfers and mentioned that Sue's pointers have significantly improved her coping strategies. She's truly appreciative of Sue's dedication and willingness to go above and beyond. So great job, Sue, and thank you for enhancing our patients' lives. Okay, we're going to pivot now and talk a little bit about value-based purchasing. For those of you that were on our call last month, we started to bring forward some of the payment model changes that were coming, and Wanda, Ron, and I wanted to take a little bit of time today to dive into that a little bit deeper, and realizing that moving forward, this is going to be the basis of how we're going to be reimbursed. So what is value-based purchasing? It's healthcare payment model that rewards providers for the quality and value of care they provide rather than the quantity of services they perform. VBP aims to reduce inappropriate care, improve the value of healthcare services, and identify and reward the best performing providers. So VBP can help to increase our accountability for all staff members. It holds healthcare providers accountable for the cost and quality that they provide. So that's UH as a whole and all of us that work within UH. Again, reduce medical errors, reduce and eliminate errors related to misdiagnosis, medication administration, or unnecessary treatment. Also aims to improve satisfaction. And then it also, from a patient standpoint, encourages healthy lifestyles, improving communication with patients, and increased standardization in approaches to care. So this slide that I put up here, just for your reference, and again, Christina will post this on the DWP, but understanding how value-based care is transformed, there's really two sides to this. There's the payment transformation, and then there's also the care transformation. So through the care model transformation, the redesigned care model is on focus with primary care and prevention with chronic care management and a high quality, low cost episode of specialty care. And then with the payment transformation, there's the redesign with the reimbursement model, focusing on paying for the quality and appropriateness of care. And we'll get into that a little bit deeper in the next couple of slides. So when we talk about shifting our healthcare models, we look at some of these avenues here that we're supporting at the agency. So we've got continued private insurers that are going to a PDGM model, which is a patient-driven grouping model, and there is no fee for service. Again, for the us that have been in the healthcare business for a long time, we used to provide a service and then bill for that. So now they're saying we're going to give you X amount of dollars. You need to manage the episode and then manage your reimbursement from there. So with our calculations, we've averaged that through the agency, there's about an average number of visits, which equal 11 per episode, give or take. And our average length of stay is between 35 and 37 days. And actually, for our previous reports that we ran, we're actually down a day to 34. Our goal is to really get those episodes that are appropriate, 30 days and under. Medicare wants us to start the episode, front load our visits, stabilize the patient, and move them along the healthcare continuum. Our LUPA rates are 9.4. That's the goal that we should be working towards. And right now we're anywhere between 11 and 12%. So that's really come down from our days of home care home base where we were upwards of in the teens and low 20s. And then again, just a lump sum cost that we're going to be getting reimbursed for. We have to manage that. And then we're looking at expected outcomes and patient-driven outcomes to the best of our ability. All right, next slide. So with that, I'm going to turn things over to Wanda and let her get a little granular with some of the VBP information. Wanda?
Good morning, everyone. For those who don't know me, I'm the Manager of Quality, Risk, and Education. As far as the timeline for home health value-based purchasing goes, 2023 was a big year for home care, right? We had Epic going on, but also too, that was our first performance year actually where Medicare collected all our data for the performance year for home health value-based purchasing. So in 2025, we will see our first payment year, and that's based on our first performance year. Unfortunately, from our results for our 2023 data, we are going to get a decrease of 2.8% adjustment on each of our Medicare traditional payments in 2025. So we had a lot of things focusing on in 2023, and we do a lot of great work. But what can we do now? So we are in our performance year, our second performance year of 2024, and we're currently still in our third quarter of 2024. So there's still time that we all can make a difference on what our next reimbursement is going to be for the next year in 2026. Next slide. This has a lot of information on it, basically. Medicare is continuing to change all the measures. They do a lot of analysis, and they're going to change things in the upcoming year in 2025. We'll talk about that a little bit more briefly. But what I really wanted you to focus on this slide is the pie that's in the right corner. There's three things that are based on the value-based purchasing model. There are OASIS-based items, anything that's filled out in the OASIS. We get a 35% of that comes from that. Claims-based measures, and we'll talk a little bit about what those are as well. That's 35% of the cut. And then the HH caps, which is our patient satisfaction, and that's 30%, which will make up our value-based purchasing model. Next slide. So in the 2024 performance year, which we're currently at right now, the OASIS-based measures that actually impact are discharge to community, improvement in dyspnea, improvement in oral medications, total normal composite for mobility, total normal composite for self-care. And we'll go into a little bit on the next slide of those two OASIS items. Claims-based measures are rehospitalization patients in the first 60 days, and our patients who go to the ED in 60 days as well, and as well as our patient experience. our care of the patients, our communication, specific care needs, and our willingness for our patients to recommend our agency. Next slide. So discharge to the community. So basically, what this really measurement is that Medicare wants our patients to be discharged to the community. They want them to remain in the community with or without formal assistance. That's what the measurement is. So that's the goal. They don't want them to, go into the hospital as far as that goes. Some of the things that actually will take out people who are patients who die or patients who transfer to an institutional hospice or a non-institutional hospice will not be included in this measure, or patients who move out of the geographic region or their discharge disposition is unknown. So really, we want our patients to actually remain in the community. Next slide. So total normal composition. This is a big one. This is on your HSP scorecards. You know, you probably wonder what this is, but really it's Medicare's ability to capture a bunch of OASIS questions from the start of care or to the ROC to the end of the care, which is the discharge OASIS, okay? These are all risk adjusted to level the playing field. Patients that are excluded are your non-responsive patients, okay? And it's for all payers that this measure comes into play. Medicare traditional, Medicare Advantage, Medicaid, Medicaid Advantage patients, okay? So the total normal composite is made up of the self-care is made up of the following OASIS items that are right here: grooming, upper and lower body dressing, bathing, toileting hygiene, eating. And the total normal composite of mobility is the toilet transferring, bed transferring, ambulation, and locomotion. So positive change between these will increase the measure and more than a value of a negative or a neutral change. Okay, next slide. So this is actually a picture of an SHP scorecard, okay, on the top. And this is what we're talking about, the total normal composite, all right? And in this scorecard, this is actually one of our clinician scorecards. It's got a lot of data on here, all right? But as you can see, the V's indicate this is a value-based purchasing item that's going to affect. And then over onto the right, it tells you what our national benchmarks are, okay? So what are we going to do with this data? What should you do with this data? So if you're looking at your scorecard, and if you look at grooming right there, your score is 0.314. That's a deeper red, okay? So what you're going to strive for your patients is you're going to strive for, right over there to the right is the average of 0.468, okay? That's average, that's 50%, okay? So if you're low at 0.134, you want to look at those areas to improve in ways that you can actually identify what possibly are you scoring the patient in a certain way. So you're going to strive to go to green or deeper green, and which is usually the average is going to be green, and the deeper greens are going to move you over to the 75th or the 95th percentile. So if you're looking at your scorecards, look at where you are, see if you're in pink or a dark red or a green. And if you are in green, you can always have room for improvement in that as well. Now below also is actually how CMS calculates this total normal composite. It's not an easy thing, I'm going to say. So basically, this is just an example below. So basically, it's going to measure what your patient was at start of care, what your patient was at discharge, what were the maximum possible changes, like ambulation on the first one. There's possible 6 choices in ambulation. Then it's going to give you a raw data, and then it's going to divide the raw data with the maximum possible change. And then it's going to give a sum of the 3 categories for mobility and the several categories for self-change. That's how they get the sum of the normalization. But for you, look at your scorecard to see where you're landing as far as your pinks and your greens and your reds. And then the national, the average again is the 50%. So we want to be at least 50%, but if not better in the other areas. So what can you also do in any of these areas on your OASIS Start a Care? You can look at your patient and score the patient actually at their safety level. Are they safe doing the things, the OASIS items, as far as that goes? And that's prior to any interventions. I was on actually a educational session yesterday, which something hit home. And the actual presenter indicated that, you know, when we're in the hospital, you know, we want to make sure our patient is safe. We document the patient is safe. You know, we put up the bed rails. We put that there's a call button there. But in home care, that first assessment, it's kind of the opposite. We want to score them at their level. We don't want to make them safe to score them on their OASIS. Because if we did do that, we're doing a disservice to the patient themselves on improving, but also into our outcomes. It's not actually giving us the patient's baseline, which we're going to work forward to as far as all the other interventions and disciplines that we're having in the home. Another key thing is communication, interdisciplinary communication after the evaluations are done by the other disciplines. Say nursing opens a case, but then PT and OT get in and they're doing more assessments like moving the patient around. Talk to each other. You know, dyspnea comes into play too as well. Perhaps when your nurse is in the home, there's not much going on or the patient's not moving that much to get a really good baseline of dyspnea. But then when PT and OT go in the home, the patient is moving about and that's actually the activities that's causing the dyspnea. So communicate in those first 5 days to see if the OASIS is actually scored at the patient's baseline. Another thing that we can do is discharge a patient with a home visit. That's going to give us the most accurate discharging score for the patient if we actually are discharging with a home visit to give an assessment. And then also the discharging clinicians that are in the home before you're going out, communicate with each other and talk about what the patient's level is at discharge, that they improved, that they maybe are stabilized, but talk to each other. That's the biggest component right here is the communication and the collaboration. And then if you are actually the discharging clinician and you're performing the discharge OASIS, make sure you utilize the SHP tool to evaluate the OASIS. It will show you the comparison from Start a Care and it will alert you if there's any declines. So if there are declines, and let's say the patient actually is truly declined, maybe they actually are going into hospice and they're getting sicker, that's a normal thing. There's nothing we can do about those ones. Those are outliers, okay? But the majority of our patients are not doing that. So if you see a decline and you look back at the OASIS and that collaboration didn't occur, one thing you can do is say, that's really not what the patient was scored at, should have been scored at on the OASIS Start a Care. That really, I was in there and they really should have been scored lower at Start a Care. So what you can do is contact the HH Quality Pool, and I think in remote client, it's called PHH Quality Pool, and contact us and we can take a look at the OASIS, but you need to be specific on what item you're talking about. Say specifically in 1400 shortness of breath, this patient should have been scored a 3 and not a 2. We'll take a look at that. As long as you are in there, we can go ahead and make that change and send that back to the state. That's not doing anything that's inappropriate. As long as you were in there and you had the assessment, you knew what it was, we can go ahead and do that. Next slide. Okay, claims-based measures. For anybody that doesn't know what claims-based measures are, those are measures that are not driven by any OASIS items at all. When a Medicare patient goes into the hospital or wherever they go to a doctor's visit, there's a claim that's generated. So these are all generated by their patient claim. We can't manipulate this data anyway. So when our patient goes into the hospital and they're a Medicare traditional patient, that gets recorded. And that's what claims-based measures are, when they're hospitalized or they go to the ED. And this is for traditional Medicare-only patients, okay? But what can we do to help mitigate and control these claims-based measures? First thing you can do is front load, as Ken indicated, front load our visits. Get as many visits as we can in the first week, in the first 30 days. This is going to prevent our patients from going back into the hospital for reasons that we can prevent. As far as that goes, medication issues, things like that. Talk to each other. I can't stress enough talking to each other as team members and saying, hey, did you see what was going on? Maybe they opened up to this person. Maybe we can talk about what's, as far as that is going on. I just saw a chat pop up as far as front loading visit with schedules. But, you know, we have to make that a priority, though, too, as well, even though schedules are going on. Front loading the visits really have to, and that could be front loading with all disciplines, Ken. Basically, it could be, you know, we have nursing going in there, we get PT going in there, we got OT going in there, we get home health aide in, we get social worker in. All those visits we can do to help the patient as far as that goes. Medication reconciliation at each visit is very important because our patients are on a ton of medications, okay? We're not telling you that each discipline needs to do, that are not comfortable with, to do medication education. That's not it. We're just asking, were there medication changes? Are there any medications that are new that you're taking? Or maybe they're medications they just started, over-the-counter medications that they're taking that we didn't know about. So it's very important for each discipline, all our extenders, you know, LPNs, assistants, to ask the patients about their medications. It's so very important. And it also then goes to our patient satisfaction as well. That's one of our questions on patient satisfaction that our patients actually answer. Did somebody ask to see their medications too as well? Did somebody talk about the medications? And we're not doing well in that area. Fall prevention too as well. A lot of our patients go back to the ED and hospital because of falls. And one important thing that, you know, it's a very hot topic now because it's something I don't think we talked about very often, is our social determinants. What's causing our patient to actually not get the medications? Is it they don't have a car? Do they not have, you know, is there a language barrier? Is there an education barrier? And that's where we can actually enlist our care workers, our social workers, our community workers to get involved in our care to help us out as far as that goes. So those are things that we can do to help prevent hospitalization and ED use. Next slide. And
Great recap, Wanda. Thank you.
thanks.
So Christina, if you could advance one more slide, please. Team, I just wanted to go over this really quick. When we talk about value-based purchasing and how the reimbursement and payments come, I equate this to a track meet. So think about 10 people that might be running. You know, everyone's going to leave the starting mark at the same time, but you're going to have one winner and it goes from 1 to 10. So this is kind of how the bell curve is also rated. So we're going to have our top performers in the industry, and that's who we're benchmarking against. So from there, as Wanda had mentioned, we kind of want to be in the 50th percentile or higher. But that means that there's going to be winners and there's going to be losers to this model payment. So I included this to give you a visual of how things are mapped out. Next slide. And just again, to reevaluate or just redetermine our achievements. We've the work that we've done, we've been able to go from a 3-star to a 3.5-star for our CMS rating, and then a 3-star to 4-star with our patient experience. And again, moving towards a more efficient budget to manage the agency. So a lot of great work. So with that, I want to trip into dyspnea and thank Rana for presenting this morning. She's actually started her PTO, but wanted to help educate the team on one of our areas of focus. So Rana, to you.
Good morning. For those of you who don't know me, my name is Rana Farkash-Appleby. I'm a clinical care coordinator for Team 1 on the central academic market. We've been doing at our meetings for the past couple months going over one particular OASIS item. And in light of what Wanda was presenting and value-based purchasing, this past month we covered dyspnea. So I'm going to do a recap of what we reviewed. So for dyspnea, what we're looking at is, if you look at the OASIS guidance, what makes this person, the patient, dyspneic or short of breath? This is something that we identify, we assess at start of care, resumption, any follow-up or discharge. However, keep in mind that we should really be looking at how this person is performing every visit. It's not going to be scored on the OASIS that way, but we should be taking that into account. And there's the guidance as far as how the coding goes. Something to keep in mind, if the patient uses oxygen continuously on the day of assessment and the preceding 24 hours, only brief intervals without it, you're going to code them how their shortness of breath is while using the oxygen. The guidance defines that as greater than 14 hours per day. If they're using it intermittently, less than 14 hours a day, they're going to code their shortness of breath without the use of the oxygen, not based on the physician's order for the use. Next slide, please. For patients that are chair fast or bed fast, you're going to evaluate their shortness of breath based on the level of exertion required to produce that shortness of breath, whatever activities they do in that setting. 0 would indicate patient is not short of breath on the day of assessment or the prior 24 hours. If you're coding 1, the patient would be short of breath when walking greater than 20 feet or the stairs. If it's someone who's bedbound, you would assess their shortness of breath based on their bed mobility. Next slide. We are coding for 2 or 3, shortness of breath while performing other ADLs. 2 would be shortness of breath with moderate exertion. That could include activities such as getting dressed, bathing, shorter distances of ambulation, less than 20 feet, using the toilet or the bedpan. Coding 3 would indicate shortness of breath with minimal exertion. That could include activities such as eating, basic grooming, tying shoes, speaking. The guidance also indicates if the patient is just bending over to pick up an item and can become short of breath, that would also be a 3. 4 is shortness of breath at rest. An example would be if a patient has positional dyspnea, if they're having shortness of breath while supine and they use oxygen at night, you would code them 4. This would even include if the patient is not short of breath when walking or does not use oxygen during the day. If someone has a CPAP or a BiPAP, this may not be the same, and you're going to have to evaluate that individual separately and individually. However, an example would be if you have a patient who has sleep apnea or reports that they awaken in the middle of the night, short of breath, then coding 4 would be accurate. Next slide. Something else to consider. If you have a patient who sleeps in a recliner or uses 2 pillows to reduce their shortness of breath, and they do that proactively and independently, you would assess how they report their shortness of breath on the day of assessment and the prior 24 hours. If there is no shortness of breath, you would code 0. However, keep in mind, if you instruct them on the strategies, you're not going to want to code them based on your instruction. You want to code based on your assessment and their report. And that's also something to keep in mind. You don't want to just take their word for it. You want to see how they do. The big thing to keep in mind is that your patient will respond based on how you word your questions. We all know with our folks, if you ask them, are you dyspneic? They're not going to know what you mean. And you want to try to avoid yes, no questions because as we know frequently, you ask, are you short of breath? They'll tell you no. You want to ask them, when do you feel short of breath? What activities make you feel winded? When did you last experience it? You're more likely to get a better response if you have an open-ended question. This slide shows our agency over the last year from Q2 of 2023 to 2024, as far as where we fall with improvement in dyspnea versus the state. We kind of started off above, dropped down, peaked a little bit, but the deal is that we've not been consistently above the state. Next slide. We are not consistently meeting the benchmark for improvement. So what we're looking to do to improve this, there are some things we can do. And this is not a new problem. We've been dealing with this on and off for years. You want to review carefully as to what's accurate at start of care. Again, you want to look at not just what the patient reports, you want to assess them, you want to talk about the last 24 hours. If somebody falls between two levels of coding, you're going to want to code lower. We want to give ourselves credit for what we do. And I know we always want our patients to be safe, as Wanda was mentioning, but what we really want to do here is look at them when they're at their worst so we can show what we've done to improve them and get them better. If you're not the admitting clinician, but you're evaluating the patient within the 5 days and you observe something different, notify quality, as Wanda had mentioned. Also, the same thing at discharge. If you are not the start of care clinician, but you're doing the discharge and you see a discrepancy between what you remember from start of care and see at discharge, you can alert quality to make that change in coding if you find the response to be inconsistent, either via PHH quality on a remote client or HH quality on a rover. Next slide, please. Okay, any questions? Like I said, instead of dealing with that now, please reach out. Either you could reach out to me, you could reach out to your manager, you could reach out to quality. We'll all be more than willing to help you. And thanks.
Thanks so much, Ronna. Great presentation and safe travels, huh?
Thank
Ariel, we'll trip into
Morning. Oh.
metrics and agency updates.
Thank you, Ken. Good morning, everyone. Happy Friday. So we talked a little bit maybe last month about our redesign in the office. We were seeing just over the summer some barriers in our communication and not getting things maybe clearly done as faster or just that transparency. So in the office now, we are still by markets, but the intake nurses have moved over within those markets. So it's the PSCs, your care coordinators, as well as the nurses. And then we're in the office Wednesdays and Friday, but also authorization team is here, as well as the admins from intake who support the nurses. So we did send out an initial survey just to get people's thoughts of how effective this would be. So you can see the results there. And also, as I already stated, we wanted to decrease that lag time as far as the start of care or making sure that the visits are available for you, for the clinical team to schedule. So that information is also there. And as we are trialing out this new process, we are tracking a few things. The Golden Goose is more of it's not an escalation, but it's just that through the communication or what we're trying to do, we need to have a get together as a team to discuss in person or Zoom, so it can be called anytime throughout the week, but also look at our timeliness of care, any sort of escalation. So ideally, when you're in the office Wednesday and Friday with all the teams, we would expect to have less issues and making sure that we're coming to each other to have those conversations. As I said, we did our initial survey and we'll do one at 30 and 90 days. And also any new processes we're looking at. Currently, we are using capacity, determinate capacity for the markets through secure chat. So we do actually have a meeting today just to see how that is going and also look at some of our data for our admissions and visits. These are some ideas about how we can engage our staff more as far as with the markets as well as with the different teams. And we are putting some of these ideas in place, making sure that there's opportunities to understand each other's role, as well as what are those best communication methods within the teams. Next slide. This month, this month is ending, but in October, we're going to have some additional activities. Like I said, the next survey within 30 days, just to see how the in-office Wednesday, Friday collaboration is going amongst each market and the teams. We also, the manager group is reading Humble Inquiry, learning more of how of asking instead of telling. which can bridge and help develop those communication and also to build relationships. And some things that are coming up in October, if the field clinicians are in the area and want to stop by, we will be doing speed dating, not actual dating, but taking the time to get to know each other and people's interests and just setting aside some time throughout that day to take a break. Also, at the end of the month, we will have a Halloween costume party. As well as that Halloween party, we will do random acts of kindness throughout the month, as well as some additional games just to continue to work on that team building and how we can effectively partner together to get the things done for our patients, as well as getting the information for our field teams. Next slide. Some metrics. So as you know, we do share metrics at a system level to the senior leadership. And just looking at, as far as our timeliness of care, we're doing really well, as well as our census. We moved into Epic. Those efficiencies of just getting things, the workflow through, have been much higher than it has been in home care, home base. We're also looking at how many days on average that the patients are on services with us. We're also doing a little bit more breakdown compared to Medicaid and Medicare from some of the feedback that our senior leaders would like to know more about. Orders management is going really well as far as getting things signed by the field clinician, as well as those PCPs that are following our patients. There's some also tracking our referral numbers. As you know, we are looking at it, how many admissions we are doing per day. So we're tracking that. And then also our non-admits, we want to kind of keep that lower. We're still around the same as we've been in home care, home base, as well as where we have the patient scheduled for whatever reason, we don't do their starts of cares. And the conversion ratio as far as non-admit versus admissions and the number of referrals we receive has been much higher in Epic as well. When we were in home care, home base, we were at 75% conversion. And a big area that we're really focused on in the past month with our rev cycle team who processes our claims are our denials. Our denials have been steady increasing in the past 3 months. And we have to establish a work group with the office teams as well as the revenue cycle team, just to identify like what is being denied. So some things you might have seen, we have put in some new processes where we need the plan of care signed within 48 hours. If that isn't done, then obviously we can get denied for the services we've completed for that patient. And when we get denied, we don't get that reimbursement, and that is a negative to our bottom line. Another area we're working on now is with our infusion visits. So we did identify that, yes, we're putting the nursing visit in for the infusion. As long as that infusion is occurring, we're getting reimbursed for it, but we're not getting reimbursed timely for additional visits by our nurse from the certified team. So we're working with the infusion team as well as rev cycle too. This is another home care metrics that we review on a monthly basis and biweekly with our teams, just showing where we are as far as our AR and our legacy home care, home base, and within our current system. And then, as I said, we're really focusing on our primary denials now. Everything else that's green is looking good, as well as yellow, it's open denials and the time it takes for our claims to go out to get reimbursed. I think that's it.
Good. Great work, Ariel and team. I know, think of where we were 6-8 months ago, a lot of orange on that previous slide. So now it's great to see the green moving forward. Okay, I'm going to turn things over to Dave. And again, very apropos with our Epic anniversary. We've got some great updates to share, a lot of great work from our Epic advisory group. And Dave, take it away.
Hello, everyone. So October, we can see on this slide here, is going to be a very busy time for us. We actually have some upgrades going in, and then we also have some enhancements that we're placing in as well. So to kick it off, October 1st, this next week, the scheduling department is going to have access to MapIt, which is going to be presented here by Nicole. And then we're going to go into our Epic upgrades on October 16th and Day Planner on October 16th. And we'll have a couple folks presenting that here this morning as well. And then EVV is going to go in on the third week there in October, which would be a Monday. That's our electronic visit verification. So quite the busy time we'll have. And Christina, how do I do the remote? Christina, I'm sorry. Don't see it. Thank you. So map it October 1st. So we're going to go into Nicole's presentation, and we'll go to the next slide. Perfect.
Good morning, everyone. Thank you, Dave. As Dave had mentioned, Mapit is an application within Epic that will allow our schedulers to visualize the plotted route for visits on our field clinician schedules. So I want to take a moment to thank our identified super users for going on this training journey with me the past few weeks. And I know you don't see Dave's name here, but I do want to thank him as well for being our trainer and giving us some excellent training. So we did have one identified super user per market. So you see that Becky Berwick was listed for East. We have Renee Crawley on our Central market, and we have Keisha Gunn within our West market. And Gordy is our clinical ops coordinator. He went on this journey with me as well. All of our additional PSCs went through training this past week on Wednesday, and so we're looking forward to going live. As we look at the next screenshot, oh, I guess it's missing here. I thought we had a screenshot in here that would visualize the actual Mapit location, but I will just briefly, if you were seeing, I will briefly just talk about the benefits that it will have for the PSCs. So it'll help us in situations such as when we're working weekends and there's limited staff working. It will also help with call-offs and cross-coverage and same-day add-ons. So who is the closest to that patient's home at the time of scheduling those visits? And if you were visualizing the map, it would show pins, and that will help the PSCs identify where the clinician is located at the time. It will also show us which visits have already been completed throughout the day, the proximity of all of the patients, and also a comparison of capacity between staff members. So if they just wanted to look at nursing visits, they could put in filters and see just the staff for nursing. As David mentioned, it is our hope to go live with this application by 10/1. I did open an IT ticket with our IT team to see if they can put that in production for us. And the PSCs and myself will meet a few times in the month of October to see how it's going and share efficiencies with one another. And that's all I have.
Thanks, Nicola. Great summary there on Mapit. So we're going to go into the October 16th, 2024 Epic Dorothy upgrade. This is going to be presented by Christy Rush, and Christy's been very instrumental in helping us along in advisory committee as well as some subject matter expert decisions as well. So we're going to go ahead and turn this piece over to Christy Rush. In just a second, the Epic Dorothy upgrade will occur on October 16th, and the downtime is going to be in the middle of the night there, so it's going to be 1 a.m. to 3 a.m. estimate. Then there is a Cogito lockdown for all those that are going to be, working in the office that day, and for reporting purposes, now that's locked down from 3 a.m. all the way to 1 p.m. in the afternoon, so that'll carry all the way, through the morning and then early afternoon. And then there's a transparent lockdown, which understanding that Epic is such a large platform, across multiple different departments just in our agency, that there's some enhancements that have been made that need to be copied over. So that starts on October 12th. So on occasion, if you're working in the office, you might in hyperspace, you might see that it says quick action manager, that the activity might not be unavailable. And that's as early as the Saturday preceding, October 16th. So there is some downtime. These slides have the downtime procedure link right here at the bottom. So if you're looking for home care downtime procedures, they can be found here. Okay, The Epic Dorothy Playground, the slide is in here. This is the training logins you'll see for your training personnel. This is the link that gets you into the training environment. You will always log in with your username and password first, and then when you get into the system, that's where these training logins would come into play. So if you're a Hyperdrive user, you'll want to go to Hyperdrive and select the Hyperdrive PLY. If you're a remote client user, you'll want to go to remote client PLY. And then you can see again, this is going to be open for access on 10/3. I believe it's next Wednesday. So then looking at remote client, I'll turn it over to Christy Rush.
Some good stuff that's coming up for us to help with efficiencies. The first slide here kind of describes it. You can see it's a picture of our interventions. So when we check our interventions during our visits, we only can see what the intervention is, but going forward, we'll be able to see the goal description right underneath the intervention so that we can determine whether the goal has been met or is progressing, and so on. And then we can complete that goal if it has been met, or we can go into the care plan later on and update the goal, extend the goal if need be, but it'll be helpful to see the goal right under the intervention to know if it's been completed yet or not. We have lists, a task list, so you can have your appointments today, your open visits, your just names of patients and so on. But now we'll have a list that will say my to-dos. And this list will help capture a lot of times where, say we update a task on the care plan, wound care orders pop up in my head most often. Sometimes it prompts us on the bottom to then send the order to the doctor, but sometimes it doesn't. So we'll have a my to-dos list that'll not only capture any open visits we have and things like that, but also interventions that don't have the order or that need to be sent to the doctor to get signed. Thing that we struggle with a lot with our diabetic patients is that there's not always insulin instructions or readily available insulin instructions. So under the medication tab, so if you just click the medications on the medication list, if the patient has insulin ordered, there will be this banner at the top of the screen now, and you can click the banner and it'll take you directly to the insulin instructions, or it might say no insulin instructions found if there are not any in for the patient. The doctors are supposed to be putting in the insulin instructions when they put the insulin in, but we all know that that does not always occur. So we will have access to actually edit this and add the instructions for the patient from in this new upgrade. Thing that many people complain about is how often our phones are going off during visits. So we will have the option now to silence the phone notifications while we're in a visit with the patient. Now, when you have to have started your visit on your Rover device. So when you pull up the patient's home, you say start your visit. Once you do that, if you have engaged the do not disturb during visits task, you will not receive the audio notification during your visit. You'll still receive the message, but the audio notification will not go on. And to do this, you have to go into your settings under secure chat. So you would click the little red epic, you would click your secure chat icon, and to the left, there are 3 little dots, which gives you your settings. When the upgrade occurs, we will have this choice that says silence chat during home visits. If it is green, if you have it toggled to green, it's on and it will silence the audio notification while you have, when you have engaged your visit when you started at the home. One thing that's really going to be helpful is trying to solve the issue that when we don't have service, which unfortunately is a lot, we can still upload photographs or other documents if need be through the media tab. So, a lot of times, especially in rural areas, we're offline and you can't do anything. You can't upload a photo, you can't do anything. But now you would be able to go into your media tab and take the picture in the media tab, which will then upload to the patient's chart, how it would, if you were to take it under your LDAs. The other thing we'll be able to do is we'll be able to change or add annotations to the pictures that we take. So there will be the little pen icon under the picture, and you can click that and make notations, document, extra pieces of information, different things like that right within the thing.
Thank you, Christy. Wonderful presentation. So that's going to move us into another update that's going to occur on October 16th. And this presentation will be done by Brandon. And these are the super users that we have. So the day planner offers some efficiency when scheduling from Rover and remote client. Here's our super users that are listed. They're going to go through training starting this Monday. And those folks will be able to champion our change, with day planner as we move forward into the end user training following the next week, as well as our we can leverage those folks. So in our day planner, Brandon created a nice little video. And just a second here. Thank you, Christina.
David, do you have the passcode to put in?
I do, but I can't get the screen switched around to paste it. Can you read it to me?
I don't have, what is his pass?
Hold on a second. I'm so sorry about this.
Dave, it's Q2 dot J
Is
question
it
mark.
lowercase? Wait, Ken, are they lowercase?
Oh, capital Q,
Okay.
number 2,
Mm-hmm.
dot, lowercase j, question mark, lowercase v as in Vicky, lowercase z as in zebra, and then question mark. Teamwork.
Thank you so much.
Yep.
Christina, you want to share can you share screen with audio?
Are people able to hear it or no?
No.
Not yet.
One moment. All right, Dave, you gotta let go of the thing.
Even though I know my territory pretty well, it still helps me to visualize everything on a map. I met with Dave this week and was given training access for a sneak preview of Day Planner. I currently use the old version called Route Planner on a daily basis. Even though I know my territory pretty well, it still helps me to visualize everything on a map. If you spent any time with me at all, you will know that efficiency is paramount to me. I love my patients, but if I can give them the same quality care in less time, then I get more time with my wife and kids. And I believe that this is a tool that can help with efficiency. This is what it's going to look like on a laptop view. Dave did a great job labeling everything. You can see that everything is currently in TBD, but there's also a possible route, number 2. It also gives you an approximate driving time between the patients. You can pin a patient at a certain time. So if you know that Mr. Smith is the only one that will let you come at 8:30, you can take Mr. Smith and put him right there, press the pin button, and then press optimize, and it'll give you a new route based on that. You can change the addresses of your patients. You can change the start time or the end time. You can change the start location or the end location. So for instance, if you needed to end the day at daycare, you can put that in there and it'll optimize that as well. You may notice that I did not talk about number 3, add staff activities. That's because there's an entire slide for it. So you can now add planned activities instead of just logging them after the fact. I don't know about you, but I have certainly not gotten paid for various meetings and educations because I simply forgot to add them. So now you can add them in advance. For example, with a lab drop, you can add the duration of the lab drop, the location of the lab, and this is probably my favorite thing, you can link it to the patient where you're doing the lab draw. This will help you plan the lab drop into your schedule. And as you can see from here, this is a rover view on your phone, which means you can now optimize your schedule from your phone, not just from your laptop. Increased convenience. Same thing though, you can drag and drop, you can pin things, you can optimize, there's different views. So this will be rolled out onto Rover as well. And of course, it's still possible for you to log activities afterwards, just like now. You click log instead of plan, and it would be very similar to what we're doing currently. To recap, this is a much improved version of Route Planner. And I want to remind you, if you can save 5 minutes a day in driving, that's 25 minutes per week, which means 1,300 minutes per year, and that is roughly an entire day, just by being slightly more efficient. I'm going to hand it back to Dave here, and he is going to talk about location sharing and how we're going to need to turn that on. Hello, colleagues. I met with Dave this week and was given training access.
Location settings, those slides there, most folks already have location settings enabled. So what we'll see is, come the upgrade is we're going to start to see the location settings will pop up in your Rover phone if they're not set. So locations sharing, we need to do our location sharing just simply so that way this Map It and Day Planner will know where you're at during those days. So there's really no ability to optimize unless we do our sharing of our location. So there'll be more to follow on that and making sure that prior to go live that everybody's on. We're going to go into EVV. EVV is going to be presented by Lori Thompson. So little background on EVV. Medicaid started this. This is the electronic visit verification piece that SanData app is going to be replaced by a seamless build here in Epic that is going to report that information automatically for you. So it's just information about who receives the service, where you provide the service, the type of service you provide, the location, date and time, and it's tied to the GPS. So that information will definitely provide some efficiencies. And Lori, I'll have you speak for a couple minutes. How is the field clinician going to find out? How are we going to find out the first way that this patient is an EVV patient?
Well, Dave, the first way we're going to find out is when we click on our time log in our Dorothy Mobile rover, and it should pop up if they are a Medicaid patient or a Medicaid byproduct. You will see visit verification is necessary. The other way you can also find out is in your Dorothy remote. You can look under current alerts, and then you can also look to the side. You'll see there's an HHEVV Medicaid attestation form that will need to be filled out.
So
And
Lori,
where do we find those forms?
yeah. So the
Okay, I'm
consent
glad you
forms.
asked me that. So you will find those forms in the same place under documents that you would find your HH consents or your NOMNOC forms. We need to obtain an HHEVV consent form starting when this rolls out on patients that are already active on program. After any new patients that we open after this is rolled out, that consent for EVV will already be incorporated inside the general consent form.
So why would anybody do a manual entry, Lori?
Sometimes we have to do a manual entry. If for some reasons, as we all know, our mobile device is offline, we're in an area where we can't get any signal, or if a patient refuses to sign, you'll have to do a visit verification fail, and it will walk you right through. You'll have to type in reasons why you couldn't obtain that time in, time out, travel time. And there'll be all kinds of reasons. It may just say, like we see, mobile device issues, service provided at an alternate location. We all know sometimes patients go to another house, and that's not going to program us if it hasn't been entered into Dorothy Rover or into remote client.
So what are some best practice tips that we could do for mobile and remote client?
Practice tips are always to enter your time, your transit time and your transit time to and from, and your time in and out on your Dorothy mobile device.
In remote client, just so you guys are understanding, anytime you override the admin times for the visit from remote client, if you have the incorrect time in, it will prompt a manual override. So on occasion, when patients do a refusal, they do not want their GPS information shared with Medicaid, then the patient would have an override purposefully, so that way it would kick out the GPS coordinates. So that is when a patient refuses the consent. So there'll be much more information to follow. There's actually going to be a GPS that's sent out to you in the next week regarding this complete process of EVV. But when patients, refuse consent, we have to make sure that the system does not, transmit the GPS. So this is going to be the process. The clinician would, on consent, do not consent, check the box. And then in remote client, they would create a manual entry override reason that the patient refused EVV, and then follow up for awareness. We would want to place that on the alert. You can actually go to the HHEVV and place details on it that the patient refused. And then we could leverage our add directions and precautions so we can see the patient refused EVV. So that way would prompt us to do manual. There is some Dorothy mobile iPhone map settings that we can actually change to enhance the EVV process. So we'll be sending out that piece of information and having a little boot camp to change this setting to Google Maps from the Apple Maps. And then again, we have location sharing that we need to make sure that we have this enabled. Dorothy Hyperspace users will see the EVV admin. Staff will get a work queue for any manual entries to review with everyone. I want to thank you guys, and I know we're a little bit over, but I'll turn it back to Ken.
Thanks, Dave and team. A lot of great information, a lot of great work. So we'll look forward to those enhancements and efficiencies. Ms. Dottie, you online? Dottie, you with us this morning? Okay.
Sorry, I was
Well,
on mute.
oh, yeah.
I was on mute talking, Ken.
Well, we agreed with
So
everything you
good morning,
said.
everybody.
Good morning.
So you'll see a slide, and these slides will be available later. Just an update, kind of go along with the updates that Dave and the team were doing. It was identified a while ago that we did not have chart audit tools for our new EPIC documentation. So through some work groups, we're working on creating the chart audits, and you'll have education that will roll out before we start doing those chart audits, and that'll include like documentation, where would you find something, or where would you document something? So just to let you know that. And then you'll see on the screen, we do have some rehab competencies that we'll be rolling out. Thank you to Ellen Garrett, Joe Yonner, and Joe Green for helping create some of these. One is the vestibular basics, one's vision, and they will be loaded up to GPS, and we will let you know when those are ready. That will be expected to be completed by the end of the year. So there's plenty of time, even after all our updates for EPIC. So no worries there. Next slide. And just some continuing education opportunities that are out there right now that are open for registration. So when you get these slides, you can link to the registration if you haven't seen it already. And I know that Christine has had a lot of these items on the newsletter as well, so you can link. Or you can go to the Rehab DWP, scroll down to the calendar, and you can link to it there as well for registration. So just thank you, everybody. I know we're over time, so that's all for me.
Thank you, Dottie. And team, as we come to an end, I just want to project ahead for next month. The employee engagement survey results are in. All of our managers are working with HR right now to get those finalized. And then our intent is to have dedicated time to give you what those results are. And more importantly, how we're taking those results and working on areas of improvement for the agency. A lot of good feedback in there. So for those of you that participated, thank you for taking time. We'll also be doing a recap of our Joint Commission survey from 2022, and then getting ready forecasting for our upcoming survey that can happen anytime after next month. And then Dave will do a final recap of our final rollout. So please look for an invitation coming to a theater near you in the next couple of weeks. Team, happy anniversary. Thank you for all you did for our preparation for EPIC. We look forward to another successful year, and thank you to all our valued team members for the delivery of quality care. Have a great day, everybody. Thank you.